Okay, good morning, everyone. Why don't we get started? It's first of all, Happy New Year. I hope everyone had a wonderful holiday season, got some time to, kick back, relax, and enjoy time with family. It is my distinct pleasure to welcome everyone back to the Academic Grand Round series and introduce one of our newest recruits to the University of Toronto's Department of Ophthalmology, Dr. Gareth Mercer. Gareth joined the DOVS as an assistant professor just last year, and he's cross-appointed as a retina surgeon at St. Michael's Hospital and the Hospital for Sick Children, and I have the pleasure of working with him at Kensington as well. Prior to joining our department as a staff ophthalmologist, he completed a pediatric retina fellowship at Sick Kids and a adult VR surgery fellowship at Sunnybrook and Toronto Western Hospitals. He has a particular interest in the intersection between retina surgery and IRD. His research focuses on interventions to improve equitable access to eye care in Canada and internationally. And he's been a great addition, both as a fellow to the department and more recently as a faculty member. He's already taken care of some of my family members. So, Gareth, we welcome you to the DOVS family in Toronto, and I look forward to your talk this morning.
Thank you very much, Amandeep. It's a pleasure to be here. So yeah, like Amandeep said, for those of you who don't know me, I'm a retina surgeon at St. Mike's and Sick Kids, and I'm sorry I'm not there in person to join you today. I have an operating room that I'm going to at St. Mike's just after this, but what we're hoping to do today is present to you some cases of hereditary vitreoretinopathies and hopefully help you to be able to recognize patients who might have these conditions. And hopefully what we're going to be showing you is how the importance of timely recognition in these conditions can potentially save vision for your patient and even for their family members. And I'm very grateful to Joseph Hanna and Jacqueline Slomovic who agreed to help me present the cases today. And so if we just go to the next slide, I'll talk about the learning objectives for this presentation. So we aim to differentiate both the clinical features of Stickler's and familial exudative vitreoretinopathy, as well as their associated non-ocular conditions. And we'll dive a little bit into their genetic basis and what that implies for their inheritance patterns and the implications for familial screening. And last, we'll talk about disease-specific approaches to retinal detachment prophylaxis. So I'll ask Jacqueline to come on now and present the first case.
Good morning. My name is Jacqueline, and I'm a PGY4 ophthalmology resident at the University of Toronto. Today, I'll be presenting a clinical case of a patient with a hereditary vitreoretinopathy, focusing on clinical features, diagnosis, management, and highlighting the important role we play in early identification and care of these patients. I would like to thank Dr. Mercer for his guidance in preparing this presentation. Let's begin with a case. An 11-year-old male presents urgently to Sick Kids Hospital with increased flashes and floaters in the right eye. When evaluating a child with a retinal tear or detachment, it is critical to consider a broad differential. These include trauma, prior intraocular surgery, congenital or hereditary causes like Stickler's, ROP, FEVR, coloboma, and cavitary optic disc anomaly, as well as myopia. Honing back in on our case, we saw an 11-year-old male with a known COL2A1 mutation who presented urgently with increased flashes and floaters in the right eye. His history is significant for a funnel retinal detachment in the left eye in 2022, which left him with no light perception vision in that eye. He is pseudophakic OU. At presentation, his visual acuity was 20/30 in the right eye and NLP in the left. Intraocular pressure was 11 bilaterally, and slit lamp exam revealed no signs of any anterior segment inflammation, and the fundus exam showed a giant retinal tear with associated focal fluid. The patient underwent indirect laser retinopexy applied circumferentially, except inferiorly, which was difficult to visualize, and cryopexy applied transconjunctivally to the inferior horn of the tear. Unfortunately, 6 days later, he reported increased floaters, and by post-op day 10, he noted a curtain defect in the left hemifield. On re-examination, he had a retinal detachment. This case emphasizes both the severity and rapid progression of retinal pathology in Stickler syndrome and the importance of close follow-up. Now we'll turn our attention to Stickler syndrome. Stickler syndrome is a hereditary connective tissue disorder caused by mutations in collagen types 2, 4, and 6, which are essential in the vitreous, cartilage, and inner ear. It affects the eyes, ears, joints, and craniofacial structures. Although most cases are autosomal dominant, recessive forms do exist. The estimated incidence in 1 in 7,000 to 9,000 live births. There are multiple subtypes of Stickler syndrome. Type 1 is caused by a COL2A1 mutation and is the most common and presents with a membranous vitreous phenotype. Type 2 involves a COL11A1 mutation and features involve a beaded vitreous. Type 3 is from a COL11A2 mutation and lacks ocular findings. And finally, type 4 is from a COL9A1 or 9A2 mutation. Three other syndromes that are important to recognize due to their overlapping ocular features are spondyloepiphyseal dysplasia congenita, also from a COL2A1 mutation, which shares a vitreous phenotype and retinal detachment risk. Knoblauch syndrome is a COL18A1 mutation and presents with a high myopia, early retinal detachment, and encephalocele. Wegener syndrome is from a VCAN mutation and features include a presenile cataract, chorioretinal atrophy, and an optically empty vitreous, but lacks systemic features. So now we can put in a question. What cranial anomaly feature is a feature of Stickler syndrome? You can just answer in your head, or you can put your answer in the chat box below. For those of you who answered B, the Pierre-Robin sequence, you are correct. So honing back in on Stickler syndrome, systemic signs include an orofacial anomaly like a cleft palate, micrognathia, mid-face hypoplasia, often presenting as a Pierre-Robin sequence, hearing loss, which can be either sensorineural, conductive, or mixed, joint abnormalities like hypermobile joints and early onset arthritis, and finally, cardiac issues which are rare but can include mitral valve prolapse. Our next question is, what is the lifetime risk of a retinal detachment in Stickler syndrome type 1? Again, you can either answer in your head or you can use the chat box. For those of you who answered C, 50%, you are correct. Ocular features of Stickler syndrome are often the earliest and most dramatic at presentation. They include high myopia, often congenital, although some patients may have a relatively low or even normal refractive error despite a long axial length. Vitreous degeneration, including membranous or beaded. Lattice degeneration, typically radial or perivascular. Cataracts, particularly presenile or cortical opacities. Open-angle glaucoma, often related to anterior segment dysgenesis, and critically, up to 65% risk of retinal detachment over a lifetime if untreated. The image on the screen depicts extensive pigmentary changes and lattice degeneration in the perivascular distribution. Stickler syndrome is known for its vitreous phenotypes, and on this slide, we can outline the examples of the various vitreous configurations. Type 1 Sticklers has an optically empty vitreous with a retrolenticular membrane and circumferential condensation. Type 2 has a beaded vitreous, which is fibrillary, and type 4 has a hypoplastic vitreous. These findings can often be seen at the slit lamp and are a major diagnostic clue in young patients with high myopia. Retinal detachment is the leading cause of vision loss in Stickler syndrome. Mechanisms can include lattice degeneration and vitreoretinal traction. Detachment is often bilateral, giant, and associated with a high risk of PVR. The fundus image here shows a classic radial and perivascular lattice with multiple breaks and a subtotal retinal detachment. Surgical repair is often difficult due to strong vitreoretinal adhesions and recurrent pathology. Diagnosis is primarily clinical and based on slit lamp findings, family history, which is most commonly autosomal dominantly inherited, audiograms and skeletal imaging. Genetic testing for COL2A1 and COL11A1 can confirm the diagnosis, but is not always necessary. Full field ERG is supportive, but not necessary for the diagnosis, and shows a reduced B wave amplitude in both scotopic and photopic responses, prolonged implicit times, a reduced B to A ratio indicating bipolar cell dysfunction, cone dysfunction often dominates, and ERG abnormalities often worsen with age, regardless of refractive error or retinal detachment. Management hinges on an interdisciplinary care approach. Ocular management includes correction of myopia, early cataract surgery if visually significant, monitoring and treating glaucoma, and surveillance for retinal detachment, especially in children with known mutations. Systemic management includes ENT for hearing loss, orthopedics for joint and skeletal issues, pediatrics for growth and craniofacial concerns, and genetic counseling is an essential part of family planning. Dr. Mercer will discuss the treatment modalities in greater depth, but I will briefly touch upon some options. In regards to prophylactic treatment, you can consider both 360 degrees of laser or cryotherapy. Surgical management is individualized based on the size and location of the retinal breaks and the presence of PVR. Vitrectomy may have a higher primary anatomic success than a scleral buckle, but this can be made challenging by abnormalities in abnormally adherent posterior hyaloid. Returning to our patient, an 11-year-old male with a known COL2A1 gene variant with a retinal detachment in the right eye in the context of a recent PPV laser gas fluid exchange and Denseron 2 weeks ago calls the pager for a hemifield defect. On exam, despite initial treatment, he represented with a recurrent retinal detachment under oil from his PVR. This reinforces the aggressive nature of retinal detachments in Stickler syndrome and the need for both prophylaxis and early intervention. He was treated with vitrectomy, stripping of PVR membranes, endolaser, and Denseron top-up. As this image illustrates, his retina reattached and he actually did quite well. To summarize, Stickler syndrome is a collagenopathy with severe ophthalmic consequences. Retinal detachment is a common, early, and potentially preventable complication. Slit lamp examination and vitreous phenotypes are critical for diagnosis. Management must be proactive and multidisciplinary, and prophylaxis should be discussed early in life, especially in families that are at risk. Thank you again for your attention, and thank you to Dr. Mercer for his guidance on this case. I will now turn it over to Joe.
Good morning, everyone. I'm Joseph Hanna. I'm one of the PGY3 ophthalmology residents here at the University of Toronto. And I will be presenting a case where a 10-week-old baby boy referred for leukocoria in the right eye, initially noticed on exam at 6 weeks old. His normal development with term delivery, no past ocular medical history, and no medications. So here I will talk about some of the most common causes of unilateral leukocoria, and that include familial exudative vitreoretinopathy or FEVR, retinoblastoma, cataract, Coates disease, and retinopathy of prematurity. The list is more than that, but these are just some of the most common causes. Anterior segment exam of the right eye shows anterior segment dysgenesis with some missing iris tissue. Posterior synechia temporally with NVI. Retrolenticular, there is a fibrovascular membrane or mass with vascular pattern. And on the image on the right here, you can see elongated ciliary processes. Fundus photograph of the right eye that is taken during exam under anesthesia. You can see fundus picture of the right eye with hazy view, with retina appears abnormal with radial vessels behind the lens with a suspected retinal detachment. Therefore, we needed to perform a B scan. So we performed the B scan in the right eye, and here you can see a hyperechoic signal in the vitreous cavity with a closed funnel retinal detachment. Moving in and the left eye, on the right here is a fundus photograph of the left eye showing vitreous and pre-retinal hemorrhage with a macular dragging and a blood vessel running through the fovea. There are also multiple dot blood hemorrhages superiorly. On the left, there is an IVFA image of the left eye from arteriovenous phase showing macular dragging and a blood vessel passing through the fovea, with some area of non-perfusion temporally, and there is also a new vascularization leaking right here. So going on with our first question for this case, which of the following ocular finding is not typical in FEVR? A, subretinal exudation, B, elongated ciliary processes, C, peripheral retinal non-perfusion, or D, macular dragging. And I'll give you a few moments to think about an answer. You can put it in the chat box if you'd like. And the correct answer here is B, elongated ciliary processes. So to summarize our case so far, we saw a 10-week-old baby boy with leukocoria that was found to have right eye closed funnel detachment and left eye macular dragging, new vascularization in an area of non-perfusion. We suspected FEVR as our diagnosis, and to confirm that, we decided to proceed with genetic testing to confirm our suspected diagnosis. So we performed the Vitreoretinopathy panel plus, and we found him to be heterozygous for LRP5 mutation and hemizygous for NDP mutation. And then that brings me to the second question of the case. Which of the following fever-associated genes demonstrates X-linked inheritance? A, T-SPAN12, B, LRP5, C, NDP, or D, ZNF408? And I'll give you a few moments to think about it. So the correct answer here is C, NDP. It is important to note that fever can have different inheritance patterns, including autosomal dominant, recessive, and X-linked inheritance. Also, penetrance varies significantly in fever, and some of these mutations are associated with extraocular manifestations that Dr. Mercer will talk about it further. Going back to our case, this was our chronological order of patient care. So we initially saw the patient in July, that was in 2019. We performed B scan, examination under anesthesia, and laser. Same thing we did in August and September. So the patient required series of examination and laser treatment about a month apart. So we saw him initially at 10 weeks of age, and then we performed treatment at 10, 14, and 18 weeks of age. Fast forward 5 years later, this was his exam. Right eye exam remained similar. However, he had dislocated lens with white cataract, and a retrolenticular mass is still present. The MVIs are still present. The left eye, the anterior segment exam remained fairly normal. Posterior segment exam, there's still in the right eye a retrolenticular mass with a total retinal detachment. And the left eye, you can see here, he had resolved macular dragging with no heme and 360 laser scars with no exudates. And this is a fundus photograph of the left eye. You can appreciate that macular dragging has resolved, and there are also laser scars at 360 all around. Fortunately, the patient maintained 2100 vision in that eye. So speaking a little bit about familial exudative vitreoretinopathy or FEVR, FEVR defines a group of inherited retinal diseases characterized by abnormal retinal angiogenesis. This results in incomplete vascularization of the peripheral retina, as you can see in the schematic here, with subsequent retinal ischemia. A vascular retina in fever may result in hypoxia and new vascular growth, as you can see in the schematic here, with subsequent hemorrhage, foveal displacement, and may in severe cases result in tractional retinal detachment, as we saw in the right eye of our case. Fever is often bilateral and asymmetric, with a variable inheritance pattern ranging from autosomal dominant, recessive, and X-linked inheritance patterns. Fever has a staging system where there are 5 different stages with subtypes A and B for each stage. And subtype A is without exudate or leakage, and subtype B is with exudate or leakage. And here is an example of stage 1, where there is avascular periphery or anomalous intraretinal vascularization, as you can see here in the fundus photograph and the associated IVFA image. Stage 2 is a vascular retinal periphery with extraretinal vascularization. An example of stage 2 is actually the left eye of our case here. As you can see, these are the fundus photos and associated IVFA images. Stage 3 is extramacular retinal detachment. So in this fundus photograph, I hope you appreciate inferior temporally, there is an area or a localized area of retinal detachment. It hasn't reached the macula yet. Stage 4 is macula involving retinal detachment, subtotal. So in the fundus photograph here, there is a retinal detachment from about 12 o'clock all the way to 9 or 9:30. But it's not a total RD yet. And stage 5 is a total retinal detachment. And an example of that is the right eye of our case. So, in summary, fever is associated with different inheritance patterns and penetrance. Therefore, it should be suspected in cases of leukocoria. Early diagnosis and management is critical in preserving vision in patients with fever. And you can see example in our case here, our 10-week-old baby boy, where the right eye, unfortunately, we were not able to save his vision, but with early diagnosis and management, we were able to preserve 2100 vision in the left eye. I would like to thank Dr. Mercer again for the opportunity to present at Grand Rounds, and I will hand it over to him where he will talk to us more about genetic testing and the pathophysiology of RD prevention. Thank you so much.
Thanks a lot, Joseph and Jacqueline. Those very helpful presentations. Thanks a lot. So like Joseph said, what I hope to do now is try and synthesize a little bit across fever and sticklers and explain to you what I feel are the important reasons for offering your patients genetic testing, and then try and link some of the pathophysiology into our approaches to retinal detachment prevention. So we'll start with genetic testing, and generally the rationale for genetic testing in these inherited vitreoretinopathies is firstly to confirm your clinical diagnosis, because there is obviously some overlap in these conditions. For example, fever overlaps significantly with ROP and to an extent with persistent fetal vasculature. So it can help with the confirmation of diagnosis. As you heard from both Jacqueline and Joseph, there are systemic manifestations of some of these mutations that cause these conditions. And so having a definitive genetic diagnosis can also help you in refining the systemic prognosis and involving other medical services in the care of these patients. And then lastly, there's the importance of family planning and screening of relatives. The other thing that in inherited retinal diseases is often now becoming a factor for genetic testing is for gene therapy. And unfortunately, because inherited vitreoretinopathies tend to have already become manifested very early in development, it's sort of difficult to imagine how gene therapy would be used in these conditions, because the window for intervention would have to be very early within the sort of fetal developmental period. But who knows what the future might hold. So that is another aspect of genetic testing that is often relevant. And quite frankly, we're not very well prepared for doing genetic counseling from our training in ophthalmology. And so I know that this is quite an overwhelming area to get into with patients. And so if you do have patients who you suspect might have an inherited retinal disease, there are resources available to help with the genetic testing and with the counseling and long-term follow-up of these patients. At Sick Kids, Elise and Joy run the ocular genetics program. And so if you have children who have these conditions, that would be a great place to refer. And Peter and myself will often be involved in the care of some of these patients if they have retinal surgery issues. And then for teenage and adult patients, Brian Balios and myself see patients with inherited retinal diseases at KEI, and we have the facilities for doing genetic testing there, and we have a genetic counselor who works with us. And so that's a fantastic resource to take advantage of if you have patients who you would like to have genetic testing for. So moving on now to talk a little bit about how the genetics links into the retinal detachment prevention. We'll talk about fever first. So fever is quite fascinating because, as you heard from Joseph, there can be variations in a lot of different genes that can give you a very similar phenotype. And in a very large meta-analysis involving more than 3,000 patients recently, they found the prevalences of the following variants showing up in their patients. And so the most common causative genes for fever were Frizzled4 and LRP5. Then other genes with slightly less common prevalences were TSPAN12, KIF11, NDP, and ZNF408. And there are a few others that are even more rarely associated with fever. And so you might ask, how is it possible that you can get this kind of overlapping phenotype showing up with so many different genes? And it's because these genes are involved in signaling in a pathway called the Wnt or beta-catenin signaling pathway, which is involved in retinal angiogenesis during fetal development. And you can see on the diagram on the right side, neurin, which is produced by the NDP gene, is a signaling molecule that binds to Frizzled4, and LRP5 and TSPAN12 are both co-receptors for that signaling, and that then goes on to lead to beta-catenin migration into the nucleus. And so variation or variants that lead to dysfunction of any of these proteins can then lead to dysfunctional retinal angiogenesis. And it's been shown in animal models that KIF11 and ZNF408 also result in impaired retinal angiogenesis through non-Wnt pathways. So next slide. And so, like Joseph said, it's not always necessary to do genetic testing to be able to make the diagnosis of fever, but it can be helpful to know which gene is responsible in an individual patient, both from an ocular and a systemic perspective. And so, for example, with ocular prognostication, that same systematic review found that variations in the NDP and the Frizzled4 gene tended to result in more severe disease than those in TSPAN12, and that there was measured in terms of the proportions of patients who were in the higher disease stages. They also found that there was some variation in the primary features that manifested in the patients with the different gene variants. So, for example, patients who had LRP5 or NDP variants tended to present most often with retinal detachment, whereas patients who had TSPAN12 variants tended to present more often with dry falciform folds without exudation or active retinal detachment. And in terms of the systemic associations, fever has generally been thought of as a primarily ocular condition, but there are some important systemic associations with some of the genes. And so, for example, LRP5 is associated with hereditary osteoporosis and also with hearing loss. And the Norris disease protein is associated with progressive hearing loss and developmental delay. And variants in KIF11 are associated with microcephaly and developmental delay. So having a genetic diagnosis can be beneficial from that systemic point of view as well. So moving on to the next slide. Now we'll talk about the management of fever. And fever is a condition, as Joseph mentioned, that has staging, and it does tend to progress and can continue to be active throughout a patient's lifetime. And the management is really stage specific. So at the earlier stages, stage 1 and 2, where you have retinal non-perfusion with neovascularization and potentially with exudation, the mainstay of treatment is what was used to treat the patient in the case that Joseph presented, and that's with ablation of that peripheral avascular retina, usually using laser. And there may be an adjunctive role to the use of anti-VEGF injections as well. Once you begin to develop retinal detachment, scleral buckle and vitrectomy begin to become the therapies of choice. And for peripheral localized retinal detachment, scleral buckle is often a good option. But with the more extensive retinal detachments, particularly with when there's an extensive tractional component, vitrectomy is the surgery of choice. But as you can see that as you get to the higher stages, stage 5, the surgical failure rate is very high, so 71% in one study, as compared to 10% failure rate for the lower stages. So really the key here is early recognition and treatment before it gets to the higher stages, similar to with retinopathy of prematurity. As we mentioned, another important aspect of management is offering retinal examination with or without fluorescein angiography to family members, and then also potentially for screening for the systemically associated diseases like hearing, bone density, and development. So now we'll move on to Stickler's and try and tackle this condition from a similar perspective. And so again, it's quite fascinating that Stickler syndrome can be manifested by variants in various genes. But in this case, they're all related to collagen genes. And the structure of collagen in the vitreous is quite fascinating. The schematic on the right side here shows what a collagen fibril looks like in the vitreous, and it's this multimeric structure where it's primarily composed of helices of type 2 collagen. And type 2 collagen, there's only one gene responsible for that, and the gene products actually assemble into these heteromers that then concatenate into the helices. And then within the type 2 collagen, you have a core of type 11 collagen, and there are 2 type 11 collagen genes that associate at different proportions. And then collagen 9, there are actually 3 different genes. So it integrates 3 different gene products to make the collagen trimer of collagen 9. And collagen 9 has a particularly important role in linking the vitreous strands to other molecules, for example, to glycosaminoglycans. And at this stage, it's not entirely well understood why these variations in collagen lead to a predisposition to developing retinal tears and retinal detachments. It has been shown that in addition to its structural role, collagen also has a signaling role in development. And so you may end up with dysregulated TGF beta and BMP signaling during fetal development, which may in some way predispose to abnormal retina with retinal tears, and also is part of the mechanism why patients with Stickler's develop cataract. There may also be something about the anomalous vitreoretinal interface or early syneresis that predisposes these patients to getting retinal tears. So next slide. And unfortunately, with Stickler syndrome, despite the fact that there's a very high risk of retinal detachment in life, the evidence around how to prevent retinal detachment is less strong than it is for FEVR. And the variation between sites in how these patients are managed is quite high. But there have been studies looking at strategies to try and intervene before the development of retinal detachment. And in particular, in the United Kingdom, the University of Cambridge and the University of Manchester have both trialed different types of protocols for managing these patients. So in Cambridge, for many years, they've been using 360 degrees peripheral retinal cryotherapy. And so on the right side here, you see an image of a patient who has an asymptomatic giant retinal tear without detachment that's very anterior at the aura. And so the aim of trying to do cryopexy is to try and prevent these types of tears. And you can see a picture on the lower right side of the screen where you've got these cryopexy scars adjacent to one another in the full 360-degree retinal periphery. And that group studied this intervention in 165 patients with type 1 Sticklers who presented at an average age of 11 and were followed up for 7 years. And you can see that they found a lowered rate of retinal detachment to 9% as compared to 37% in a historical control group. And the group at Manchester has tried something similar, but instead of using cryo, they used laser retinopexy in kind of 4 to 6 rows from the aura to the mid-peripheral retina. And their findings, together with some other groups who do circumferential laser, were recently reviewed in a systematic review involving 400 eyes of patients with type 1 and type 2 Sticklers with a similar age of presentation and follow-up and a very similar risk reduction from 36% to 7%. However, none of these studies were randomized, and most of them are retrospective in nature. And so there are a lot of unanswered questions about really the true magnitude that could be expected, and also in the risk stratification of patients, and at what age this type of intervention should be performed. Because as you can imagine, doing 360-degree laser or cryopexy for a child often means having to do it under general anesthesia. So final slide here. So I'll just talk briefly about what our current practice is for patients with Stickler syndrome at Sick Kids. So we recommend doing periodic screening retinal examinations every sort of 4 to 6 months, starting at diagnosis, because as I mentioned, there is a fairly high risk of developing these asymptomatic giant retinal tears. We typically perform localized laser retinopexy around areas of lattice degeneration and of course around retinal breaks if those are found. But we typically do not recommend at this point circumferential treatment with laser or cryo. And as I mentioned, that's primarily because of these questions around risk stratification and optimal timing. But I do think that this is a very important area to keep discussing with patients and something that hopefully we'll be able to do some more research around to provide better advice to patients. And I do typically recommend that patients pursue genetic testing for the reasons that I mentioned earlier. And for those patients who do have a confirmed genetic diagnosis, I encourage them to register in the Fighting Blindness Canada Inherited Retinal Diseases Registry, because this might allow us to do some more retrospective research on the incidence of retinal detachment for these patients, and will allow us to have a registry of patients who we could invite to participate in future clinical trials. So thank you very much for your attention. That's the end of our presentation. And thanks again to Jacqueline and Joseph for presenting their cases. If you have questions or comments, please, we'd love to hear them now.
Those were great. I can start if no one's. I don't see anyone have their hand up, but those are great presentations, Jackie and Joseph. What always amazes me with these inherited diseases is how, and not just those that end up requiring surgery, um, but other inherited retinal diseases, how phenotypically variable they can be. You see patients from the same family with the same mutation, and they have, wildly different phenotypes and very different disease. I mean, the genetic testing obviously is very important and very helpful, but there seems to be so much more to it than just having the mutation. I'm also a little disappointed you didn't have any surgical video on that first case because I know we have great surgical video for that first patient, but next time.
You're right. Sorry, I really should have taken the opportunity to show some surgery. Anybody who's interested in seeing that, I'm happy to show that video. Um, if Jackie or Joseph would like to speak to that question, I'm happy for them to go ahead. But I agree that that is an important feature of both sticklers and fever is that there's very wide both intraocular asymmetry and phenotypic variability within families who carry the same variants. So that's a feature of autosomal dominant disease, conditions commonly. So it's not just restricted to these two. And it would take someone who knows genetics a lot better than me to explain all of the reasons why that is. But there are a number of different potential explanations for why there is such variability with these variants.
I mean, Joseph touched on, variable penetrance of some
That's
of
right.
these mutations, which probably tells part of the story, but there's so many different layers that some of which have been figured out to some extent, but very few of which have been explained.
That's right. And some of the things that are being discovered for other inherited retinal diseases is that there can be modifier genes as well. So people carry non-pathogenic variants in other genes that can modify the severity of presentation of a pathogenic variant in a different gene. So that can also be part of the explanation for why there's so much variability in these conditions. But for sure, variable penetrance is an important one, and variable expressivity of these autosomal dominant conditions is a key factor. Oh, and Elise is here, so she can. When I talked about someone who knows genetics much better than me and can answer these questions, we've advanced someone to the panel.
Garrett, I want to congratulate you and Jackie and Joe. Like this was an outstanding presentation, and it's an important topic because both those phenotypes can go unrecognized. And like Garrett and I discussed this, like there's no clear answer on how to best manage these cases. In terms of the phenotype variability, we don't have a clear answer, but you need to remember that we all have a different genome. Like Garrett, Peter, and I, believe it or not, could be brothers and sisters, but we just all carry a different genome. My sister's 5'6", right? So, and I just wanted to make a point about the genetic testing, and that in this condition, I find it's very important because there's a risk of systemic associations. And specifically, an LRP5 is associated with juvenile osteoporosis. And I remember, I'll never forget, your first kid that you see that had like 7 episodes of fractures, and they just blamed it on being a little guy and being clumsy. But it turns out that he had juvenile osteoporosis. So those should be referred to endocrinology. But I think the point that you highlighted well is that Stickler and fever, though they present at eye diseases, we should consider them as systemic conditions until proven otherwise, and they're complex. But thank you, Gareth and Peter, because they're on the speed dial for these cases. And it would be nice that we figure out a way, especially for the sticklers, to say, okay, that we have an internal approach, at least to try. What should we do? Like, because currently we just observe. And I had the last comment when you say that it seems that there's more retinal detachments in fever. So I'm just wondering, do you think that maybe is that the fever cases presenting more as an ocular condition are picked up later and that the fever phenotype is missed? And that's where it's important to recognize the straightening of the vessels and the fever phenotype. It was just a thought I had. And anyway, thank you. I think it was a great session.
Thank you very much, Elise. I'm not sure I quite understood the last question, but I don't know that it's necessary that fever has a higher incidence of retinal detachment than Stickler's does, for example, but just that some of the fever genes.
Oh, I thought that's what you said in one of your studies that you read. So I'm sorry, I
I might have.
misunderstood.
It's possible I misspoke.
Oh,
I guess what I was trying to say was from that systematic review, they found that some of the fever-associated genes, LRP5 and NDP, tended to present more commonly with retinal detachment, whereas TSMAN12, for example, tended to present more with the macular dragging and falciform folds. So that there was some ocular variation, and they felt there was some phenotypic variation based on what the genotype was for their patients.
there's a question in the chat by Hiba and Kate Leahy, who we don't know who's from Australia. Hiba
Yeah,
asked,
so,
any
so a
advantage
couple of
in doing a
questions.
buccal of it? Oh, sorry. Okay, I cut your
Oh,
grass.
oh
Sorry.
no, yeah, go for it, Elise. Go for it.
Yeah, so I'll read out those questions, and if Joseph or Jacqueline feel like they want to jump in, they're welcome to, otherwise I will. So Hiba asked, is there any advantage to doing a buccal vit for the Stickler case when they initially detached in January? Did you want to say anything, Jacqueline, or shall I go with that? No? Okay. I mean, that's an interesting question here, but there isn't really strong evidence that a combined buccal vitrectomy is superior to a vitrectomy for retinal detachment in general. And doing a buccal can sometimes make a vitrectomy repair of a giant retinal tear more challenging. It's also more surgery, and so for a monocular patient, you have to balance the risks of how much you're going to do to their eye. If you mean when they initially presented with the giant retinal tear, I think we made the decision because he was monocular and the detachment was limited, that the least invasive thing to do was laser. And if it had worked, we would have been heroes, but that wasn't the case, which is so often true in surgery. But for sure, people do buccal vits for patients with sticklers, and there isn't strong evidence that it's superior, but some people, that is their practice.
And it probably doesn't, I mean, in the setting of a giant tear, it probably doesn't make a whole lot of sense. I mean, if you think about the reasons why buckles are useful or helpful, none of them really apply when you have a 6 clock hour giant tear. I mean, you're not, it's torn. You don't need to, you don't need to reduce the peripheral traction. It's already relieved itself by, tearing the retina for 6 clock hours, especially if you're going to use something like silicone oil or Densron.
So then Kate asked, can fever be so asymmetric as to have a normal fellow eye with normal fluorescein angiogram? I can't show you a case that confirms that, but there's never a never in medicine. So I'm sure there are patients who have that degree of asymmetry. But sometimes when we see patients in the clinic, the question is whether they might have coats versus fever. Generally there you're looking for the fellow eye being pretty normal in coats versus typically in fever you would expect to see some degree of peripheral retinal non-perfusion, but it may only really be detectable on IVFA. And there are some patients with coats who also have asymmetry in the other, asymmetric disease, but have some disease in the other eye. So it's not 100%.
And it kind of depends on your threshold for normal. I mean, if you if you do an optos angiogram on everyone, everybody sort of has some peripheral non-perfusion. If they had a falciform fold in one eye, you'd say, oh, there's evidence of the fever in the fellow eye. Um, which I mean, Elise can comment better probably, but I think, when we do investigate family members of kids with fever, we see, sometimes we see frank abnormalities, or sometimes we know they have only one functioning eye, but oftentimes we say, oh yeah, look at that. Makes me wonder, if they weren't the parent of a child with fever, we would pass it off as a normal variant, but
Yeah, I agree with you, Peter. And that's really the pain in the neck of autosomal dominant disease, isn't the variable expressivity. And I agree. Sometimes I overcall stuff but you can never, like Garrett says, you can never rule out never. If it looks like it and you think it's it, it may be it. And so do the genetic testing. It may help, and then follow them and examine other family members. Yeah.
Okay, well, thank you guys. Excellent discussion and great presentations. Gareth, Jacqueline, and Joseph, thank you guys so much. We don't have grand rounds next week, so we will reconvene in 2 weeks' time. Enjoy the rest of your day, everyone. Thank you.
Thanks, everybody.